Well, thank you for Dr. Coleman for inviting me, and it's a pleasure to be here. Of course, you heard my two esteemed colleagues, and I'm pretty sure you're all running to give maintenance therapy to all your patients. My job is to tell you that maybe it is not necessary to do so. So I'll be talking about no maintenance. So what is the goal? The purpose of maintenance therapy is to prolong remission duration and life expectancy without compromising quality of life. Now, what are the strategies we have? So first strategy is chemotherapy. So if you're going to give chemotherapy, it has to be low-intensity chemotherapy to eliminate or suppress the minimal residual disease, and that would be an ideal strategy for maintenance. But in the future, we will have immunotherapy, antibodies, checkpoint inhibitors, vaccines, etc. So most of today's discussion about do we want to keep giving chemotherapy as a maintenance therapy, and that is the debate is all about. There are controversies, so let's see what are the controversies. First is, when would you say you would start the maintenance therapy? You should do maintenance therapy if you're going to do it after maximum tumor site reduction has been achieved. This is somewhat simple if the patient you're talking about maintaining them after auto transplant. But if it is a matter of non-transplant, whether your induction will be 6 months, 9 months, 12 months, 18 months, it has a major impact on the outcome, and you will see that. So in the non-transplant, when you would put a patient through, so you cannot say giving 6 months of treatment for whatever response they have and randomize them to one arm continuous therapy and the other arm you stop the therapy, and you will get exactly like Palumbo's trials that they all start relapsing as soon as you stop taking the medication. The controversy is also on the endpoint. Is progression-free survival a surrogate for overall survival? And what about Antonio Palumbo talking about PFS1 and PFS2? He showed you that PFS2, it was sustained, so you got to maintain everybody. So we'll have to look at that controversy. And patient subgroup. Do the good risk patient have to be maintained? Maybe high risk patient are the one who should be maintained because the disease comes back quickly, and if they come back, you are not able to effectively control them or treat them and they die quickly. So maybe we should restrict our maintenance therapy. So let's look at the controversies in greater detail in order to understand what is the role of maintenance. And I'll use the same slides, but you can understand what different speakers are saying. So first is, progression-free survival is not a surrogate for overall survival. So first of all, when you are in remission, you're talking about maintaining somebody in remission who's already in VGPR. So their M spikes are 0.5, or somewhere in that range. So minimal change to call them somebody progressed, 25% increase in paraprotein, that has no impact on the survival outcome of the patient. Okay? But it makes a big difference in the progression-free curve in terms of who relapsed and who didn't. But in terms of survival, it has no impact, and that's why people have tough time showing survival impact. The frequency of measurement is arbitrary. Some studies do the patient comes every 2 months, another one does it every month. So the one which monitors them very closely will have an earlier relapse, progression-free survival shorter. Someone who monitors you come once every 3 months, your progression-free survival will be better. Median absolute increase in progression-free survival. This, Antonio clearly said, 6 to 9 months improvement in progression-free survival is of no consequence. It does not impact the overall survival. Post-progression therapy, it also has a major impact on the influence on the overall survival. So now there are maintenance improves progression-free survival and overall survival. There are studies to that effect which is shown there. But it could be maintenance improves progression-free survival, but not overall survival because of crossover. So the patient got, lenalidomide, who didn't get it, they crossed over, they got it. Or because of long-term toxicity, like thalidomide, they couldn't take it beyond 6 months. So it really couldn't show an overall survival benefit. The other one is altering the tumor population, inducing drug resistance because of chronic administration of low dose of chemotherapy is an ideal condition in the lab to generate drug-resistant clone. Is that what you want to do for the patients? And altering the microenvironment, evolution of aggressive clone and myelodysplastic syndrome. So these will all impact on the outcome. So maintenance improves progression-free survival and overall survival. Okay, what are the studies? You can clearly show that if you do the studies in Greece or in Spain, if you have no access to the novel agent upon relapse, then clear-cut you will be able to show that the patient who went on the good treatment with novel agent, they did very well, and the people who didn't were randomized to standard arm. When they relapse, they have no access to the study novel agent, so they all ultimately died. And so this is shown in a cartoon fashion, what I was talking about. That studies coming from Greece, etc. Those patients, they get randomized, they get novel agent up front. Fantastic. But if they relapse, it's not United States, those patients have no access to the novel agent. So you want survival advantage? Do the study in Greece. Okay. So let's do progression-free survival duration. Okay. Thalidomide versus no treatment, you have a progression-free survival of 7 months. This is the study from England, MRC IX, thousands of patients. 7 months, it would have no impact on overall survival. Then you have lenalidomide, which shows very good. As Palumbo said, he prefers lenalidomide. He sends them to beach, and they are still taking the pill. But I'm going to tell you, go to the beach and not even take the pill, because you don't have to call Berenson, you are having a DVT. So here you are. When you take the bortezomib, you could see 9 months. Again, bortezomib is a washout. Whether you give it by mouth or IV or whatever, it's a washout. Okay, so we washed out 2 drugs. Let's go on and look at the one which stands on. So the thalidomide, as I told you, no survival difference. But what is also important, you have to be careful, is that sometimes you can actually adversely affect the patient by your maintenance. And this is shown on this high-risk patient. Those who got thalidomide, they did poorly upon relapse. And that's an important message to keep in mind. So high-risk patient should not get thalidomide maintenance, because once they relapse, they do poorly. All right. But there are strategies which does help high-risk patient. So this is the HOVON trial, which has been shown before. So those who got VAD and thalidomide maintenance, which is on your left-hand panel, and those who got PAD, which is bortezomib or PS321, bortezomib, there you can see even the high-risk patient with deletion 17 and 414 translocation, their outcome was still better than patients who got thalidomide maintenance or basically no maintenance. So we do know, using proteasome inhibitor, we have changed the outcome of patient with 414 translocation. Induction, if you use transplant, fine, but again maintenance or continuous therapy does make a difference in a subset of patient with high risk. All right. Now you heard a lot from my esteemed colleague, Palumbo. He introduced the PFS2 as an option. So maintenance improves progression-free survival, but not the overall survival, because it could have long-term toxicity. It can alter the tumor population, inducing drug resistance and altering microenvironment, evolution of aggressive clone. In order to address this issue, the European Medicine Agency, which is like FDA, EMA, they demanded that once the patient, you show improvement in progression-free survival, PFS1 with your maintenance, subsequent therapy is also important, because they all relapsed or had refractory or developed leukemia or died. We want PFS2. So they said, let us get PFS2. So as usual, my colleague Dimopoulos from Greece published his 999th paper showing that PFS2, when you do MPR plus R, is better than if you do MP or MPR without lenalidomide maintenance. So PFS2 was better, and just now you heard Dr. Palumbo saying that, yes, PFS2, whatever benefit you got, it was not lost on their subsequent therapy. Let's look at it a little more closely. I don't have to tell you what is PFS2. It goes from first-line and second-line therapy. But let's look at Antonio Palumbo. His talks are great. He talks beautifully. His slides are very clear. And I thank you, Palumbo. This is his slide he has provided. So here he shows MPR PFS1. So you see on the top, PFS1 is 31 months for melphalan-prednisone lenalidomide with lenalidomide maintenance. Whereas for melphalan-prednisone, it was only 13 months. So then let's look at their subsequent salvage treatment upon relapse. So salvage therapy, first of all, very fewer patients relapsed on maintenance lenalidomide arm. So 62 patients out of 152 didn't even relapse. They are still enjoying their first remission. But among the 85 patients who relapsed, most of the patients got bortezomib because they are progressing on lenalidomide. That is correct. So they got bortezomib. Now let's look at the melphalan-prednisone arm. So they had melphalan-prednisone, and then when they relapsed, most of them relapsed, and most of them got lenalidomide. Okay? So the MP only got lenalidomide. The MPR got bortezomib. So if that is true, then I should compare PFS2, melphalan-prednisone with late lenalidomide versus melphalan-prednisone continuous lenalidomide. So what is the outcome? 31 months and 28.8 months. No difference. Whether you used lenalidomide up front right away or you gave lenalidomide upon relapse, the outcome is the same. Afterwards, these patients can also take Velcade. That's a totally different ball of wax. Okay? So that's important to keep in mind. So this is the same kind of thing, Palumbo published just now in JCO 2015. So you have the first trial, which is again continuous lenalidomide versus RDMPT, fixed dose therapy. So now we use the term continuous therapy with fixed duration therapy, FDT. All right, so 3 trials. So before I go that, one thing I wanted to point out, which I always said is, treat the patient until maximum response. Nobody says maintenance will play a role if you are not going to give maximum, you are not going to treat the patient until maximum response. So if you look at RD continuous infusion, which is highlighted, CR plus PR is 75%. But if the patient got 18 months of lenalidomide dexamethasone, you see that patient also got overall response rate of 73%. So you need to treat long enough. Here they gave 18 months of treatment. But if you give MP for only 9 months, then you have already designed your trial with a clear-cut message. You know it is going to be positive and you know it's going to get in New England Journal. Right? So you give only 8 months and you get a very low response rate, 50%, and then you do MPR plus R, you got a 77%. So you got to treat the patient to a maximum response. Okay? Otherwise, you can easily show a difference. So now PFS2, this is Antonio Palumbo's ASCO presentation. I had to fiddle along with that curve to get this. So you could see fixed duration of therapy, PFS2, is better than continuous therapy, PFS1. That means if the patient got lenalidomide continuously, or if the patient got upon relapse is equally good, even in this large trial. So absolutely no study so far has clearly shown you maintenance has made a difference. Of course, there could be secondary malignancy, etc. That was why the EMA asked you whether you want. But it's not a major problem. Still, relapse is a problem. So what is my conclusion? Guys, if you're talking about chemotherapy maintenance, first of all, treat the patient adequately till maximum tumor site reduction. This was what my colleague, I think, Dr. Chari said, that you want to aim for MRD with all the tools you have. Then, if the patient is already in good remission, good risk, you don't need to give maintenance at all. In high risk, I think there is a role for continuous therapy. Post-transplant, if the patient still didn't even achieve a VGPR, there are data to show a second transplant does better. And this is more recently HOVON trial in which the Germans gave 2 transplants following Bart Balagi, and the Dutch did only 1 transplant. They showed that the good risk patients who were not in complete remission, second transplant did improve their outcome for majority of those patients. Then there is a new terminology introduced by the Europeans, which is called consolidation. After doing the transplant, you're giving the whopping dose. Now giving Revlimid 25 milligram and Dex 40 weekly is called consolidation. Hello, that's big dose therapy after a transplant. So you give consolidation, and that could help you instead of going to Revlimid 10 milligram. So you can consider maintenance not in VGR patient or better. So if the patient at the end of transplant is not in VGPR or better, if you don't want to do consolidation, you don't want to do a second transplant, then of course they should at least get a maintenance. But the future, I'm pretty sure, again, Antonio Palumbo will be coming and tell you, the whole field has changed now. It is immuno-oncology. You got to use elotuzumab, checkpoint inhibitor, vaccines, etc. And I'm looking forward to his elegant presentations in the future about different way of doing maintenance and not use any of the chemotherapy we are talking about. Thank you.